Assalamu alaikum. Good afternoon, everyone. Okay, because of the short nature of these, I'll just go directly into the case. The case is, I called it basically catastrophic consequences of a side branch loss. 74-year-old woman with worsening chronic angina. She has long-standing history of paroxysmal atrial fibrillation, and she was on apixaban for that. Previous TIA, prediabetes, hypertension, dyslipidemia, obesity, the whole thing. She has severe bilateral knee osteoarthritis, and often when she comes to clinic, actually, she's in a wheelchair. And despite the fact that she has very limited mobility, she was symptomatic. She had preserved LV ejection fraction, and she had underwent cardiac CTA at an outside hospital for further assessment because of this chronic dyspnea and angina. And it showed basically significant calcification and disease, mainly in the LAD and the LCX. Okay? So initially she was offered CABG and PCI, but she was reluctant, and she went into trial of medical therapy, and she was still symptomatic, despite good medical therapy. So finally, she agreed. Okay. So this is the diagnostic angio. This is the right, no significant. She's got mild, maybe to moderate disease in the proximal segment. Same here. And it's actually calcified on CT. And this is the left. You can see there's also significant disease in the OM. Doesn't show well here, but you have heavily calcific disease in the LAD proximal to mid segment involving, involving the two diagonals. And this is just more view. You can see that she's got significant disease in the mid segment mostly. And it might not project very well here, but the second diagonal is involved as well. That's a reasonable size, as well as the first one, which is, I think, it would be fair to call it moderate in size in terms of territory, but not the actual diameter. So anyways, I was hoping to stop and ask what would people do, but because you don't have time, defer to the end. So anyways, I just decided to go protect and do the usual work. My focus was, to tell you the truth, the LAD, but I was very concerned about the second diagonal because its size, I thought it was big, okay? So anyways, I did predilatation, okay, and also I used the same balloon to basically stretch the ostium with the second diagonal because I had a feeling that it will not stay around if I stented across it. So that was an attempt to preserve it up front. Anyways, I went with 275 by 28 Ultimaster stent. I just decided to do it and avoid the very proximal part of LAD to make it less complicated of a procedure, because I know that I'm going to run into potential issues with the first diagonal as well. So it was pinched after I put the stent. I tried to recross, swap the wires just to keep entry into the diagonal, but it was very difficult. So I decided to do post-dilatation optimization. I did it with 3/0 by 8, okay? And that's actually when I lost the diagonal completely. I don't have view for it, but anyways, what happens is total loss, severe chest pain, AKG changes. I just left the D2 wire gel in place, multiple trials to go through the stent into the diagonal, but failed, and it's totally occluded the ostium. I used different wires, including, tapered tape wires, but nothing would go. So after basically I exhausted my attempt to go in proper way, I had to go behind the stent because the patient was having severe chest pain despite a very decent dose of analgesia. So I used low profile. I went behind LAD, and it was difficult to push it, so I had to anchor actually balloon into the distal stent and just use it to force the balloon behind, and just to stretch the ostium open, and that actually was successful in restoring the flow. Then after that, a good 20 minutes, 30 minutes, basically to go inside and cross. After now, I gained some flow into the LAD. I'm sorry, into the diagonal. So I recrossed actually mostly using the LED wire. Anyways, I could basically post-dilatation, and I stretch the other with balloon, and final with kissing balloon inflation. And I thought after that, the final result was actually acceptable. Chest pain almost resolved. It had decent flow. I went back to the proximal, the 3.0 to optimize it, okay? And I was actually satisfied, okay? I think that a reasonable result for this lady. Anyways, 30 minutes post-procedure, she was still in recovery. She had severe chest pain, and she had anterolateral ST segment elevation. Took the lady back, and diagonal is gone. Okay. And she was in severe pain. And you can see also the proximal part of the stent is filling defect, most likely clot in it. And that would make sense with the changes in the AKG. Anyways, I just focused on that idea and put a wire, and not to bore you with the details. I went back, basically, I opened it, and when established decent flow, she was still having pain. So I decided that I have to go back and basically save the diagonal. And I just repeated the same painful procedure, but I had to go through the stent this time, basically. I pre-dilated and finish it with kissing balloon inflation 3.0 and 2.0. And I have to go back, and I used 3.5 by 15 NC to optimize the stent, because I thought probably one of the reasons I just disrupted the platform when I went behind the stent, okay? And this is the final result. And you can see now, it also basically opted not to go with any stenting for that diagonal, okay? And this is the final result. So I just leave it here for initial discussion, and I have some questions. If not covered by discussion, I can ask it.
Great. Thank you very much. Just for me to understand. So the patient had a severe chest pain, then you went behind the stent to the diagonal, yes? Then you left
initial
it
PCI.
Yeah, initial one, yes.
Initial PCI, yes. We lost, basically pinched. So it was from 80% initial narrowing to 99. It was just hanging by a thread. I couldn't cross. I just did post-dilatation part, hoping that it will stretch it open. We lost it. Severe chest pain. So and I have to go across. I couldn't. Then I just decided enough is enough. I went behind because I jailed the wire. Okay? So I used it, and I just went behind to stretch it open.
That's it. And
this is the initial one. Then I managed to go usual way across, part, etc., kissing balloon inflation, the initial one. Then after that 30 minutes, you had the STEMI.
Most of the time it works, but unfortunately this happens. So your input here.
Thank you. I mean, it's a recognized way of dealing with occluded stent. Do you think, or occluded side branch, do you think the balloon was a little undersized in that diagonal? It doesn't look that big, but maybe this is why the 2.0 did not allow you to do,
for the kissing balloon inflation?
Yeah.
Final. I used 2.0. Okay, and my strategy was just to keep it open, to tell you the truth. I don't want to have dissection and lose it, okay?
No, sure, understandable. Just because sometimes you get the carina shift, and also the ostium, instead of being kind of circular, it becomes elliptical. It becomes very difficult to treat. But yeah, going behind the stent, the important thing for anybody who's going to be doing this, to make sure there's a balloon in the LED before you cross it behind the stent.
Because he did a pot. That's why it was difficult for him to go
sure,
behind.
But if you are going to go behind the stent, there should be a balloon distal to the stent. So when you go behind it, you could bring the balloon and dilate it so you don't get stuck.
Yeah.
You have questions yourself too?
Any other comment? Who would have gone for upfront? Territory-wise, I think you can see second diagonal is very decent. Who would have gone with two-stent strategy upfront?
We expect the diagonal to close down. So in a way that I would expect it, I would have done something that Saito does, trapping balloon technique. I trap a balloon and deploy the stent. It keeps the flows intact. Then I can rewire easier. So you can save a stent, keep the vessel open instead of struggling and then getting all the anatomy bad.
Can I ask just if these lights can be dimmed a little bit
Dim the light, please.
at the back?
So you heard about OCT before, صح? You know, that's I think where we need imaging. But of course, most of the time we don't do imaging. That's why maybe I've forget about the stent. I do DCB most of the time. Okay, Khalid.
I mean, looking at the diagonal, it's like an LED equivalent, okay? You may think like Collat or whatever, maybe DCB, but now you went with a single stent, so you did a great job, by the way. The only thing, ABCs, all ABCs, when you have acute closure, you may think about 2B3A. You will not have like for 12 hours.
That's what I did second time. But my question again, so I did not do, obviously, a professional stenting all the way, but who would have decided to go back second time and do two-stent strategy? Anyone?
Maybe two-stent strategy is a little bit difficult to accept because of a quite small diagonal. That could make it maybe complex. But I wanted just to ask a question. It might happen, actually. You have an occluded diagonal. It's very frustrating to feel the procedure that way. And sometimes maybe two ACA inhibitors might help. You just put the patient on two ACA inhibitors.
We did not do it up front, actually, after the first one, but we did it after the second one. Why? Because of age of the patient, previous stroke. I mean, I was reluctant, and she was on Abixaban, all these things.
Yeah.
Great case, by the way. With the second imaging, there is definitely a filling defect in the LED. Right? There's a clot. So you wonder what's the etiology, what happened? Was there a dissection in the diag, or the diag occluded, or there is maybe deformed stent from going behind it, or it is a proximal edge dissection from the initial stent that probably extended into the diag. So that's why I think maybe imaging would have been helpful in kind of also the decision about should I stent more proximal, expand the stent more, or maybe add another stent to the diag.
I totally agree. So that particular day I had no access to imaging, unfortunately, but yes.
I mean, I'm going behind the stents. You've already, the stent is not properly posed, isn't it? So it's at risk of getting thrombosis. That's
yes.
why I think.
Yes.
I mean, that's
so just to make it clear, the only reason that was disrupted, actually, I used just actually the probably two struts into the LED. So I did not disrupt the whole stent. It wouldn't make sense. So it's just to get, some opening in the ostium.
We need to move, then we have more questions, please. Thank you.
Give him one chance. Question?
Chance.
Yalla, quick.
You jailed the wire and the diagonal has gone. So I would have taken the wire out because the jailed wire moved the ostium of the diagonal and tried to recross blindly. There is nothing.
It's a risk, actually, that I wasn't willing to take, tell you the truth, because that jailed wire my lifeline.
Yes. All right. Dr. Hamid Alghamdi from Saudi
Thank you very
Arabia.
much.
Thank you very much for sharing the case.